pediatric certification program with them.
Wonderful. And finally, Dr. Suresh.
Thanks, Yoko and Tim. Good afternoon, everyone. Happy to be here. I'm Srinivasan Suresh. I go by Suresh. I'm a pediatric emergency physician here at UPMC Children's Hospital, and also serve as an informatician and a vice president for the hospital. I'm a proud member of the American Academy of Pediatrics and have the opportunity to work through COCIT, which is the Council on Clinical Information Technology, and always happy to talk about health information technology. Thanks for Drummond for setting this up.
Wonderful. So to provide context for this webinar, Tim, can you explain why Drummond created a voluntary pediatric certification program?
Yeah, so, I think, over the past decade, starting with the HITECH Act and ONC subsequent involvement in, defining at a Fed Reg level, sort of basic capabilities and functions that EHR should have. And with it, sort of this push, as Dr. Szabo was talking about, that the transformation, from paper charts to digital health, that was incentivized largely through CMS and their Medicare incentives. And sort of as an unintended consequence, the pediatric world sort of got left behind. There wasn't strong incentivizations to move to health IT and electronic health records. And so, as the years sort of progressed, we kind of saw that in pediatrics. And so when Congress passed the 21st Century Cures Act, they had recognized that and sort of shown a spotlight on, doing something, to help, bridge the gap with digital health in the pediatrics world. And so it was really at that time that Drummond, saw the opportunity to, really build and help define, a set of capabilities and functions kind of specific for the practice in the world of pediatric. And we saw that, those kinds of helps that could be in EHRs, would help clinicians on the front line help improve, child health and child health outcomes. So, that was our impetus for, helping to bring together a distinguished panel of pediatric clinicians and EHR implementers and other stakeholders in the pediatric world to sort of set about and define what those requirements, what those capabilities and functions should be in a pediatric EHR, and then build a certification program around that so that we could, help drive adoption of that and sort of raise all boats in the EHR world to provide the sort of necessary health IT capabilities to assist pediatric clinicians. And so that's kind of how it got started and where we came from.
Terrific. And Rich, Office Practicum is the first EHR vendor to successfully pass the Drummond certification program. Why did Office Practicum, what value did they see in going through certification?
Well, I think as Timothy had mentioned, it was pretty obvious that for pediatrics, there was not this set of defined baseline capabilities, functionality, requirements for a system. It did kind of get left behind a little bit. And so we were thrilled to work with Drummond to kind of help build that platform. And from our end, working together really helped Office Practicum as a system, self-analyze, look at our strengths, our capabilities, areas for improvement. And by this collaborative process of working together to define these testing scenarios, I think it really helped to fine-tune and identify like the real world needs and requirements of a pediatric system. So as pediatrics continue to evolve, I think the EHR that represents pediatrics needs to as well. And for us, I think it was important to complete that certification because it I think it sends a message, at least for office practicum, that we strive to maintain the highest standards for performance and functioning, and that, again, the needs of pediatricians and the capabilities of such a system are vastly different from that of the world of adult medicine. So being certified, it helps office practicum to stand out, as well as give prospective clinicians and tools to evaluate and differentiate between vendors and platforms and their capabilities.
Thank you. And Dr. Suresh, I mean, coming from the viewpoint of both a pediatrician, a practicing pediatrician, as well as a member of the AAP, which is now recognized, the Drummond Pediatric Certification Program, what value do you see, for clinicians?
Sure, Yoko. Just to reinforce Rich's point, the certification is voluntary, right? So that means we will have vendors sort of step up to the plate, so to speak, and go through the fairly extensive checklist. The certification criteria is pretty robust, so that's going above and beyond from the vendor's perspective. And the second point is this is not a one-time certification, and if I recollect, it's once every 2 or 3 years. So that means the standards have to be kept up, updated with newer regulations and guidelines. And Rich or Tim alluded to this a few minutes ago. Unless you're in like large children's hospitals, in most large health systems, pediatrics is about 10%, maybe 20% of the overall book of business, so to speak. So clearly in a minority. So that is where the need for such standards and certifications and updates become vital.
Thank you. It's almost a mantra in the pediatric world that kids are not little adults. What are the unique aspects about pediatrics, and what tools and capabilities do pediatric clinicians need from EHRs to enhance health outcomes? Dr. Suresh, do you want to start with that?
Sure, I can go, Yoko. I'll talk about some pediatric functions. And when I say pediatric functions, these are not limited to the care of children. Some of these are needed for routine and standard adult care, but they are more important in pediatrics. So that's why I'm going to classify these under pediatric functions. And in no particular order, we would want to get to medication dosing by weight, right? That needs to be very easy and seamless. Another point is recording information on guardianship. So we should not be going through hoops inside an EHR when pediatricians want to do that particular function. A big one is immunization management. And needless to say, this is important for health maintenance. There are state and federal regulations which make it a little bit complex. And at a very basic step, when we talk about immunizations, especially multiple vaccinations on the same day, we need to know the manufacturer of the vaccine, the lot number, the date, the site, the route, expiration date, etc. And also, in some cases, maybe a special consent form. And what happens in cases of vaccine refusal from parents or caregivers? How is that recorded and documented and saved? How do we link to immunization systems? And especially in practices which are, in border states, you could have the patient from one state and the practice is another state. Now, how do you go with the regulations? Catch up for delays. When there is delays in the immunization schedule, is that decision support in the EMR to say this is the new catch-up schedule? And occasionally we get serious side effects or true allergy to vaccinations is pretty rare. But when that happens, is there a easy mechanism for documentation of such events? So those come under immunization management. And a couple of other quick points on pediatric functions is growth tracking. Again, needless to say, it's part and parcel of routine pediatric care, well child care, and we will need to track height, weight, head circumference, BMI with the percentiles, and also the need for specialized growth charts, Down syndrome, Turner syndrome, etc. Should be easily available. And finally, just one example for a device management, taking a peak flow meter as an example, and the normal values when a child uses a peak flow meter is based on age and height and sex, if I remember right. So even providing values and reference range, it's going to vary a lot. And unlike adult normative values, you can't just have one number there. So these need to be built in, and there is a longer list, but those are sort of very critical pediatric functions that are unique to the care of children.
Rich, I'm
Suresh,
sure you have
I
a
would
lot
agree with
to add.
I would agree, Suresh, with everything you said. I would emphasize a few parts. There are many aspects of pediatrics, obviously, that differ from adult medicine and are the backbone of treating children. Pediatricians need the ability to document, monitor, and evaluate development. Development is a huge one. So developmental milestones, developmental surveys, early identification, and then being able to take action on children who may have concerns about developmental issues. Immunizations, like you stressed, are vital for pediatrics. So pediatricians need a system to not only assist in the evaluation of the status, but also from a workflow standpoint, be able to help um, effectively order, administer the shots, track inventory, forecast vaccines, like you mentioned, multiple vaccines, delayed schedules. Um, you talked about families, the ability to be able to track and organize within a system a family based on family medical history, social history, financial history, all of which may be different in many different family setups. Um, and then prescribing. Pediatric prescribing is so different. It's the weight base that you touched upon is very important, and being able to easily and accurately calculate medication doses based on weight per kilo divided X number of times per day is vital for a pediatric system.
Thank you. Now, what about the importance of privacy in EHRs, particularly for teens and adolescents, given the current political climate of politicians stigmatizing the LGBTQ issues as well as limiting abortion access? Tim, do you have any thoughts about Drummond's approach for privacy
Yeah,
issues?
I can start with that, and of course, these privacy and security issues with is not just a teen and adolescent, but I think in particular with adolescents and with teens, um, and with pediatrics in general, it can be a much more complicated situation, and we can get into some of the specifics. I'm sure, probably following my comments, but my thoughts here are, as we sort of as a uh, as a health IT and regulatory industry sort of are rushing headlong into sharing of data. Um, and it's been through either CCDAs and now, Fire APIs is the next step in that. We're rushing headlong through there, but we really haven't sort of solved the um, the patient's empowerment to consent to share parts of their health data. Uh, Typically, right now, the way things are, patients either opt in to share their data or they don't. So it's either all or nothing. And if you have sensitive data, whether you're an adolescent or teen or an adult, doesn't matter, that you prefer not to share, but yet you want to share the rest of it. Um, there's few options for that to actually happen in the health IT data sharing world, and it's not just really a technology problem, although that's part of it. Um, it's also legal and policy and a lot of things that have to kind of change and be addressed. But not being able to tag, just certain elements of your health record that you don't want to share can set a patient up to have inequitable health care, or just in situations where they need medical care, but the attending clinicians don't know the whole story, and they don't even know to ask the patient if you would mind sharing with me the other parts of your health record, so that I can make sure that we give you the best care possible. So sort of addressing this, these privacies and consent to share issues that are still sort of latent out there is a big thing, and even more important, I think, in pediatric care, where there's often um, mental health screenings and results. It's part of it, or as you said, Yoko, um, teen sexual health, could be involved, and that there could be some things there that, you know, that the children don't want to share. And so, it's a thing that, I think as a community, we have to, um, we have to get there to where we're able to, empower patients to share only parts of their, um, health record if that's what they want. And, Drummond's been, um, involved in helping to create an independent work group that's addressing that. And pediatric clinicians, Hannah Galvin and Sue Cressley, helped to form this work group called SHIFT, and Drummond helps to facilitate that. And there's a lot of um, stakeholders and folks in the community that have healthcare community that have joined that, and we're working towards helping to address these privacies and consent to share. But we're only part of the way there, and hopefully one day we'll be able to take that work and sort of augment our pediatrics certification program to help encourage and provide a way for EHRs to finally close the gap on empowering patients to to selectively choose not to share some of their health information. I know it was a long sort of winded thoughts there, but I felt I wanted to set the stage for kind of how critical this, where we are right now in the climate and the landscape, not only socially but even from a technology standpoint, with rushing along sharing data.
Dr. Sabo, what about Office Practicum and how they're currently addressing privacy?
Well, Timothy, I think you hit it right on the head. These are flashpoint issues: privacy and confidentiality, and adding in data visibility. All three taken together, these are vital components of medicine, and they are especially relevant to teenagers. They are relevant throughout, but the ramifications of a lack of privacy or confidentiality are extreme, are worrisome. They range from social, emotional, physical issues. So I'll speak generally related to what Office Practicum does, but any system should be able to address privacy and confidentiality. I would argue they have to be able to address it. So from Office Practicum's standpoint, every staff member using OP is assigned specific role-based permissions. So you can be a general user all the way up to a supervisor or a system administrator, and that role-based permission will define which areas of the system you even have visibility and access to. So that's a start. But to further protect privacy, there are levels of visibility that can also be assigned. And these range from any staff member to clinical staff, all the way through providers to author only. So these levels can be set in multiple different areas in a chart: diagnostic tests, problem list entries, prescriptions, surveys, encounter notes, visit notes, all the way up to the entire patient chart. And so the higher the level of visibility access, the fewer people who can view that information. So that's an important way to really allow specific aspects of a patient's chart with their permission to or to not be shared. But it's also very important to remember that you have to stay compliant with the 21st Century Cures Information Blocking Act. So when you're making decisions on changing levels of visibility, you have to take that into account. I think you touched on it as well, Timothy, that there are a ton of differences in rules, in definitions, for state to state or state versus federal level, and that can certainly have an impact on privacy and what is shared. I would agree that a tremendous amount more work still needs to be done on this issue.
Thank you. Dr. Suresh, do you have any other thoughts on this topic?
Yeah, just a couple of quick points, Zoko, and Tim and Rich covered most of it. Not just the variation between states and state versus federal, so to speak, but it also, in some cases, depends on the presenting problem or the chief complaint. Is it related to mental health or not when a teen presents for care? The issue of assent. How do you manage this for a 12-year-old versus a 13 to 18-year-old versus a 19-year-old? In most cases, thankfully, the adolescent has to give explicit permission for the parent to review his or her records. What about pregnancy in teens? Not very common, but still the rules are a little bit different for a pregnant 17-year-old versus a pregnant adult patient. And one other quick point related to privacy, not related to adolescent or teen privacy, is the care of children who are in foster care or custodial care, which is has its own barriers and constraints. And in some cases, the parents have no rights to custody, but the parental rights are not terminated yet, and they can still have access. So how do you manage those? So these are pretty big, important, and unique problems with which pediatric EHRs have to deal with.
Thank you. I'm going to shift over to the AAP. So, Dr. Suresh, how does the AAP influence health IT legislation and the health IT industry? And what are some of the current pediatric initiatives of the AAP that involve the role of health IT?
Sure, Yoko. I'll explain this in like probably three different buckets. One is for the legislative part, and then the pediatric initiatives. Most of it is through policy statements, and also talk about the child registry. So AAP, for those on the call who are not familiar, American Academy of Pediatrics is a premier professional organization for pediatricians worldwide with over 60,000 members. And COCIT, which stands for Council on Clinical Information Technology, is one of about 90 councils, sections, and committees which AAP has, which covers all aspects of pediatric care and advocacy. And in COCIT, we have over 400 pediatricians as members in our council, with a pretty good mix of hospital-based general pediatricians and subspecialists like myself and community-based pediatricians. Our mission in COCIT is to advance the effective use and growth of information science and technology for child health through advocacy, education, and leadership. So as far as legislation, there is a distinct office of federal advocacy out of AAP's Washington, D.C. office. And through that, some great work is done. I'll give one example, which is fairly recent. We had an opportunity through the AAP to respond to an RFI that came from Senator Cassidy's office. This was just last month, on a document that is titled Exploring Congress's Framework for the Future of AI. And I think this document is publicly available. This was put out by the Senate Committee on Health and Education. And the theme was what and how the oversight and legislative role of Congress, how should it be set up for the integration of artificial intelligence in health. So there were lots of specific questions. I'll just mention a couple. What practices are in place to mitigate bias in AI decision making? And who should be responsible for determining safe and appropriate applications of AI algorithms. So there's an opportunity through COCIT, through AAP, for pediatricians to respond to such questions, which will eventually impact, policies on the care of children. Additionally, AAP has worked with congressional offices to get the provision on voluntary certification of pediatric EHRs, Rich and Tim talked about it, into the 21st Century Cures Act. Also worked with ONC, which stands for Office of National Coordinator for Health IT, to develop EHR functional priorities for children, which goes into the model format. And that's always an ongoing project. It's never-ending work. AAP also advocates for pediatricians who are navigating Medicaid meaningful use requirements and for federal appropriations for health IT research. So that's from the legislative side. From a policy perspective, through the journal Pediatrics, which is where our policy statements are housed. And I'll mention a few examples of the statements put out, not just by COCIT. These are primarily driven by COCIT, but there is very good representation and engagement and oversight too from the other councils and sections and committees, and eventually approved by the board of directors for the AAP before the policy becomes public. So way back in '96, this is just of historical interest. The policy statement was for safeguards needed in transfer of patient data by section on computers and other technologies. So that's a cool sounding name for the precursor of COCIT. And in 2007, another publication was the special requirements of EHR systems in pediatrics. And since that was a while ago, we are currently reviewing that. 2019, my colleague, Dr. Emily Weber from Riley Children's, led the publication of a policy statement on electronic communication of the health record and information with pediatric patients and their guardians. Another example is in 2021, I think, Natalie Pagler from Stanford published in Pediatrics on this was not a policy statement, but it was titled under Perspectives, Implications of the 21st Century Cures Act, specifically in pediatrics. Some of the documents which the AAP is working on, which are very related to health IT, is integrating web services and applications to improve pediatric functionalities in EHRs, access to critical health information for children during emergencies, looking at what's called the EIF, the Emergency Information Form, looking at immunization information systems. And one other document, which is currently also in revision, is health IT to support pediatric medical home and also adolescent privacy. The last point I'll make regarding AAP's involvement is we're also standing up the Child Registry, which is an acronym, CHILD, Child Health Improvement Through Longitudinal Data. And the idea here is to collect various types of data, EHR from contracted pediatric practices, publicly available health data, claims data, and maybe patient-generated health data too, and provide the aggregated data back to the practices for peer benchmarking, and then help the practices trend safety, quality, and patient experience metrics. So very, very engaged and ongoing involvement from the AAP.
Thank you very much, Dr. Suresh. So along the theme of regulatory environment, what challenges does a pediatrics-focused EHR like Office Practicum face in navigating a regulatory environment that is primarily focused on adults?
So there are a lot of challenges. One is keeping up. So you have multiple different agencies. You have the ONC, you have CMS, the AMA, you have HIMSS, you have policy or regulations requirements on billing, coding, forecasting, vaccinations, coming at you from a variety of different agencies. And one of the challenges really is teasing out what is specifically relevant to pediatrics versus what is a kind of global regulatory change. Data set interoperability, those types of things. So just kind of weaving through all of the different sources and resources. Number one, to find out what is required, and then number two, what is required but also directly pediatric relevant, can be challenging. The other challenge is once you actually have that information, is figuring out how to implement it in the system. So this is especially challenging for these universal regulatory requirements that may not be specifically relevant to pediatrics. So it is something that's required. You have to put it into the system, but it's not something that a pediatrician as the end user would maybe find useful on a day-to-day basis or relevant. And so how do you end up putting it into the system in a way that's the least invasive or intrusive and not altering or changing workflow significantly for the end user? But it is a lot to keep up with.
Yeah, I can imagine. We're already at the half hour, so maybe 5 more minutes of discussion so that we leave room for questions, Q&A at the end. So what are some positive developments in the use of EHRs? I attended the AAP's national conference at a COSIT session, and if I remember correctly, in 1972 is when the first EMR EHR was created, and then in 1991, only 10% of clinicians used an EHR, and now as of 2023, approximately 90% use EHRs. Dr. Suresh, would you like to start?
Sure. Thanks for providing those numbers. They sound about right. Probably 10% 30 years ago, and now we're up in the 90% usage. I would say data-driven and evidence-based care. The best example I can provide is how guidelines, which all of us access on the web and in publications, but these guidelines for care, whether it's a child with asthma, child with cystic fibrosis, etc., these are important documents, but these are also pretty static documents, right? They're either a PDF or hosted on a website. How can these and how should these be integrated into the bedside care or point of care through order sets and power plans and smart sets? So thereby we ensure standard of care and reduce variation. So that is, to me, is the biggest bang for the buck in the evolution of technology and widespread EHR adoption over the last 20 to 30 years. And keeping in mind that this is expensive. It's not easy to do it. Information technology is expensive, health information technology more so. So kudos to everybody involved for making this happen.
Dr. Szabo, any thoughts?
I think it's important also to recognize that as technology has expanded, so has the expectation, especially from this generation of very tech-savvy parents coming in, to have a pediatric provider that is comfortable using technology. So, um, rapid access, rapid response, and demand from the providers to be able to utilize their knowledge and tools and share it in a more rapid way. So I think that really has put a big push on the development and enhancement of functionality of something like a patient portal.
Very good. I think we have time for one more discussion point. Everyone recognizes the benefits of digitizing health data to make it more portable and exchangeable, but there are the unintended consequences like additional administrative burden, namely click fatigue. So, what are your thoughts? I'll ask Dr. Zabo about this as the EHR vendor about balancing digitizing data versus overburdening clinicians.
So I think click fatigue is a connotation that it's probably pretty prevalent out there, but I think that as a natural part of this 20 to 30-year real increase in technology and capability of EHR software platforms themselves, that the developers and the companies are much more aware of this. And so they're more cognizant of the need to look at workflows, both when they're first designing something or when they're modernizing or improving efficiency. So to kind of bring in a concept of both useful and usable, and a system really needs to be both, and they're not the same type of concept. I think that in general the mindset has definitely moved more towards the idea that the EHR should just work intuitively, that a provider should not have to stop and think about where to click, what screen to tap to, what to do next. The system should just run in the background, and the end user doesn't really even realize that it's there. They just interact naturally with it. And I think that as technology improves, um, the design of these systems is going to continue to improve to strive to reach that goal.
Thank you. Dr. Suresh, any thoughts on this topic?
Yeah, real quick. Click fatigue is real. It's there. I see it as a practicing emergency physician. But if there is a case to be made for additional clicks, whether it is an alert popping up, where the care will be safer, it'll be higher quality, better outcomes, and not just to check off an administrative metric, then most clinicians will be okay with it. So it's a trade-off, but as long as we get better outcomes from it, most clinicians won't mind a few extra clicks.
Yeah, that's a great point, Suresh, especially when building in something like clinical decision support or this, enhancement with AI.
Yep.
Terrific. Well, I know that we can go on and on because there's so many topics, but we want to leave room for Q&A. So this concludes the discussion portion. Please feel free to submit your questions. And if we aren't able to address everyone's questions, we'll take note of them and follow up with you after the webinar. I have a first question. Does OP have a function where you can block specific parts of a record from being shared into the patient portal so that specific information is blocked from notes that are shared with parents?
That's a great question. And yes, we do. And that speaks to that visibility setting. So by default, anything that is labeled as any staff member will transmit over to the patient portal. But anything that is raised any level higher, so clinical staff, provider only, physician only, or author only, will not go to the portal. And that can be as individual as a diagnostic test, a medication order, a survey or survey result, or an entire note.
Thank you. We have another. I'm sorry.
So Yoka, let me just make a comment. So this is more general than maybe something specific in OP, but one of the things about privatizing certain data that is something that I think the whole community is sort of struggling with to some degree, is that it's pretty easy to tag specific data, but if certain data that needs to be privatized is inside like a clinical note, that's a big narrative piece, a big section of text, I think it's harder to find that and sort of tag that as private to not be shared. And we kind of touched briefly on maybe one of the uses of AI, and I think that this is potentially a good use where AI could potentially be tuned to kind of go through clinical notes and find things that are possibly subject that might need to be privatized or redacted from sharing, I should say, not redacted from the record, but just from sharing. And I think that's one of the potential promises of AI. Maybe Suresh has a comment on that too, without belaboring this question and this point. But I think things like clinical notes and other narrative pieces are particularly difficult to privatize.
Okay. Dr. Suresh, did you have anything to add?
No, I think Tim said it right. If I can digress a little bit, going to specific AI-based applications, I mean, there is a lot of talk, a lot of excitement, and a lot of hype, right, that comes with potential applications of AI, even specifically related to the care of children. And two of the areas where I feel it will really benefit pediatricians and hence patients is to reduce the administrative burden. That is so real. Technology and our billing processes have certainly increased the screen time for pediatricians. And when I say increased screen time, not in a good way. So where AI can help us maybe draft initial, especially generative AI, ChatGPT, and those kinds of tools, draft initial responses to messages from parents and insurers and the like. So that'll definitely be helpful. And then Tim was talking about another point a couple of minutes ago. One of the machine learning driven tools that we have at UPMC Children's Hospital Pittsburgh is a tool called CHIP View, CHIP as in CHP, Children's Hospital Pittsburgh. View is Virtual Intelligent Early Warning, which is a homegrown tool for sort of a sepsis alert. It's for deterioration of clinical deterioration of patients. So using existing data in the EHR, which may not be fully available to the nurse, the doctor at that time, but using ML tools, we are able to quantify the risk for a patient who may need to go to the ICU a little bit earlier, so that the care is optimized. So lots of areas where AI can certainly help improve the care of children. The key is to narrow the focus a little bit and look at proof of concepts or pilots, and then hopefully get some outcomes data.
Okay. I think we have time for one more question. What about mobile health and apps that connect to EHR so that data is more portable? Is this becoming more common? Tim, do you want to take that?
I guess I can. I was thinking maybe Rich, possibly as a EHR sort of developer, would have his finger on the pulse a little bit more. Certainly, with from my perspective, with sort of the advent of FHIR APIs, which the purpose is a way for data to be shared, more readily with smartphone apps, web apps, and things like that, empowering the patient to be more cognizant and more aware of their health data and involved in their healthcare. I think that's a big purpose for it. But like a lot of things, not every app you use on your smartphone is the best, and there's been plenty of cases that have come out where certain app developers and organizations have not been good citizens with with consumer data that they collect, and that's the case, and it could be the case in healthcare data too. So I think at Drummond we're looking to help make sure that mobile health not only in the future will be certainly something readily available for consumers and patients to use, but also that they would have the confidence to know which apps or are good. And so we're working and launching a mobile app, Fire application, client app certification program ourselves. So we're starting to think about that from the consumer and patient end of it as well. But I'm curious if Rich and Suresh has other thoughts as well.
I think that's a great point. I think FHIR APIs and the standards and regulations that will be associated with them as far as for medical data transmitting are going to be a very burgeoning field right now. And I think that they will help to kind of clean up the number, usefulness, and effectiveness of the vast number of medical apps that are out there, some of which are outstanding and others may not necessarily perform the way that they should. And then to be able to transmit that data to the end user system so that the provider is able to take action based on the data that they're coming in. I think that is something that's going to continue to evolve relatively rapidly, I suspect. So.
Okay. So very quickly, we have 2 minutes left. Final question. What are your opinions on the uptake of FHIR and USCDI within pediatric HIT? Are we moving the needle, or is it still a slow uptake?
I can start, I think. So I think in general, there's a slow uptake of FHIR and the client apps. I think we're still in the very early stages of this technology and what it can do. So so I'm not sure it's necessarily just a pediatric health IT issue per se. I think there's more to come from the marketplace and the uptake of FHIR and also USCDI. But so let me just start with that, and I'm curious as to, I don't want to take up too much time because we don't have much left. To see what Suresh or Rich thinks about that as well.
Yeah. Really quickly to add, APIs are the way to go. Rich mentioned it. FHIR is the standard to go. That we need to adopt that, but there is progress, but it's been slow though. We don't have the promise of FHIR and APIs in general. It's not fully realized yet. It's also not easy. We have 2 FHIR-based clinical decision support interventions in my hospital here, and it took us a while to build it. So on paper, it looks great, and the demos look great, but it actually takes time to build it. So I would still say that that's the way to go. That's a standard we need to use. We talked a little bit about portals, but that itself, if you look at generally the smartphone usage and the engagement of especially in pediatric patients, the families with portals, and how can and should we use APIs to improve functionalities of portals, not just for messaging and medication refill and sharing images and the like. So those are exciting areas to develop.
I would agree completely, Timothy, when you said that it's still a relatively slow uptake, specifically for something like USCDI, which is evolving and changing year over year over year with new additions. And so your vendor's system may already account for parts of it and need to make specific little tweaks to account for additional data, or there may be sections that you need to build out something new. And again, as you build something new out to account for something like a new USCDI requirement, are you doing it in a way that's not invasive, that's seamless, that is an efficient workflow for the end user?
Thank you. Well, we very much appreciate the questions and thank all the viewers for taking the time to attend this very interesting discussion. Thank you again to our distinguished panel, Dr. Rich Szabo of Office Practicum, Dr. Suresh Srinivasan, CMIO and VP of UPMC Children's Hospital and Chair of AAP's COSIT, as well as Timothy Bennett, Strategic Director of Strategic Healthcare Initiatives at Drummond. We are providing a QR code where you can book a free consultation with Drummond to answer any of your questions in more details. Thanks again for taking time with us, and have a great rest of the week.